And thank you all for being here this evening. Before I introduce our panel, I'd just like to say a word about the Cardus Health program. So the mission of our program is to foster a social system that supports the desire for natural death, equips social institutions to support patients and caregivers, and to develop a continuum of care that for those who are approaching the end of life. Now, practically speaking, that means that we conduct research, we host events like this, and we engage in the public square on issues that range from palliative care, as well as to what we're discussing this evening, euthanasia and assisted suicide, also known as MAiD. So we do have a number of research papers and events coming up through the fall, so that if you are not already subscribed to our email list, I would invite you to do so. My card is also on the registration desk when you entered, so feel free to be in touch if there's anything you'd like to share with me as well. So, of course, this evening we are focused on the topic of euthanasia and assisted suicide, and we have a panel who have a range of experience to help us better understand how did we get to the current medical assistance and dying regime in Canada, and where are we going from here? So I'll introduce our panel, starting with Ray Pennings, the Executive Vice President of Cardus. I just got confused with the Supreme Court decision there. He's the Executive Director of Cardus and the co-founder. He has years of experience in industrial relations, public policy, and politics, and also has experience in health policy. He's been a voice of concern to the media and in public affairs forums on the issue of MAiD and its expansion. He also co-led our 2016 roundtable on palliative care that we co-hosted with Pallium Canada, and he produced our 2015 report, Death is Natural. And his work has culminated with making Cardus Health program a full-time program. So thank you for the job. Dr. Andrew May is a palliative care doctor. He's practiced life and dignity affirming palliative care for the past 15 years. Since 2015, he's made it his mission to care for those who are suffering so that they feel that they can choose a natural death rather than feeling that they need to choose MAiD. He was the medical director of Hospice Care Ottawa from 2013 to 2018, and he currently works at St. Vincent Hospital in Ottawa. Dr. Sephora Tang, last but not least, is an assistant professor in the Department of Psychiatry at the University of Ottawa, where she is program director of the Psychiatry Residency Training Program. Her experiences as a hospital-based psychiatrist have led her to advocate for the marginalized and vulnerable people who need access to quality medical and mental health care. She has testified as an expert witness before the Senate, as well as the Ontario government, on these sorts of issues, and she currently serves as a council member of the Ontario Psychiatric Association. So let's get our discussion started. So Ray, I would like to start with you because it feels like since the Carter decision, which I already referenced when I was trying to introduce you, since that time, a lot has happened where we've had the initial parliamentary bill in 2016 that established some exemptions for people to access euthanasia and assisted suicide, the great degree of expansion in 2021. And we also know that a lot of people are choosing to die through euthanasia primarily, as well as assisted suicide. The numbers that came out in 2021 showed that it was over 30,000 since 2016. And the numbers in 2021 show that it was 3.3 of all the deaths in Canada that year were MAiD deaths. So how did we get here? What are the cultural and political forces that have brought us not only to the legal and cultural situation, but also just the number of people that are choosing this?
Thank you, Rebecca. Let me first of all thank you for accepting the job along the way. We are thrilled that Dr. Vachon is our health program director and quite excited about where this program can go. It's interesting, you know, you mentioned 2015, and ironically here at Cardus, we did not have a health program at 2015. We really, apart from the occasional commentary and punditry I do on all sorts of issues, hadn't really touched the subject. And obviously the events that led to the Supreme Court decision put an urgency on it, such that we, I conducted the various interviews that led to the production of Death is Natural, and since then a pretty steady stream of events. So it has, in 2015, became an issue you could not ignore if you were serious about dealing with the public square and concerned about the sanctity and dignity of human life. That said, I don't think the story starts in 2015. I could answer this with a detailed timeline, if you will. I'm going to skip that. Instead, I'm going to plug Dr. Tang's chapter 17 in the forthcoming book that was just published online and will be available at the end of August. And I believe we're doing a book. Is the date set for that?
Book launch is September 19th here at Cardus.
September the 19th, there's going to be a book launch here of a book on MAiD that actually is quite remarkable in the range of academics that have contributed to that. I've seen the table of contents and some things, and I understand Dr. Tang's timeline is far more thorough than the one that I could give you. So I'll just say, come back September the 19th for the timeline and other details. Let me just make 3 observations in terms of how we've gotten here, just from a sort of a macro level. The first, so up until the early 70s, suicide was actually in the criminal code. Suicide was decriminalized in the early 70s. And already with that discussion, it moved from what about assisted suicide? And the hard cases, obviously, are the ones that usually are brought up in that conversation. I looked it up this afternoon. Dying with Dignity Canada was actually got their charter and registration in 1982. They began organizing in 1980, and they were officially an organization in 1982. And I highlight them not because I'm a big fan of what they stand for. In fact, I'm quite opposed to almost everything they stand for. But I highlight them as a very successful organization. They have, in a very concentrated and strategic way, coordinated a strategy over the, from 1982 till today, over the last 40 years, that has seen Canadian attitudes almost totally change. They have won not just legally and politically, they have won culturally. And if you look at their website and you look at their material, they've done so very intentionally. It's not an accident. They began very much by taking some of the hard cases, but transforming the issue of one of morality and criminality to an issue of rights and compassion. And so the general public understands this issue as a choice between a certain moral imposition or being compassionate. Well, which side do you want to be on? So when you take a look, and we can document, what is interesting is in the 80s and 90s, you started seeing almost annually, there were a couple of MPs from Quebec, but almost annually you had a private member's bill proposing euthanasia. They all got defeated, some by, I looked up a couple of the votes, 280 to 26 or whatever. But there was persistence in terms of keeping the issue alive. And there was a changing of the public language and just the steady drip that took place over that long period of time. So the first thing I would highlight is the fact that this is no accident. This was strategic. It was intentional. It took a coordinating or planning mind, and they actually did quite well. The second point I would make is that if you win the language debate, you usually win the game. 1993, Supreme Court of Canada deals with the Sue Rodriguez case. Sven Robinson, those of us who are of a vintage, and I'm conscious that most of my colleagues aren't, so I sometimes have to tell them stories of the olden days. Back in the olden days, we had a Supreme Court decision around euthanasia that the pro-life side won, if you will. The euthanasia was not there. What's interesting is I pulled down the decision and did a control F and used the word suicide. 299 times in the 1993 Supreme Court decision, the word suicide is used. Fast forward a whole bunch of stuff that happens between 1993 and the 2015 Carter decision. Do a control F on the PDF of the Carter decision, 45. The language has entirely changed. We're no longer talking about a suicide. We're talking about the provision of health care. There was a Senate report in the 90s talking about quality of end-of-life care. This is a health care. The issue has been transformed entirely in terms of its language and in terms of its framing. So, number one, top-down, strategic ways and tactics. Two, change of language. And thirdly, why have they, I think, succeeded? And it's hard to get good numbers. You may be aware that Ipsos ran a poll just a few weeks ago. 80 some odd % of Canadians are all in favor of it. And it was commissioned by Dying with Dignity. What's interesting is the choice in the poll question. So do you support a religious institution not providing medical, a publicly funded religious institution not providing MAiD, assisted death to its patients, resulting in intolerable suffering? That's the word that's actually used in the question. Or do you think that everybody who receives any public money should be forced? Well, 80 some odd % are against intolerable suffering. Well, guess what? I am too. But that's the sort of polling that has gone on. We have done in 2020, we did a poll in partnership with the Angus Reid Institute, and we're going back in the field. We did another one earlier this year, and we'll be going back in the field shortly. As best I can tell, I'd like to believe our poll questions, even though I don't like the results, are actually fair and designed to get the real results. The real results are this: about 1 in 3 Canadians are pretty well totally convinced in support of assisted dying and its expansion for almost everybody. About 1 in 5 are almost opposed for almost everybody. And then there's about 50 to 60% of the population that if you ask a question that puts some boundaries around vulnerable people, minors, if you put some questions around boundaries, you'll get the support of 50 to 60% of people who really are in favor of the availability of assisted death, but want to make sure that, are sensitive to the fact that it can be abused and want to make sure it's dealt with. That's roughly where we are today in terms of public opinion, as best I can tell. How has the public opinion changed so dramatically from the 70s till now? It's been strategic. It's been top down. I actually think they have won by telling better stories. When you actually take a look at the Carter case, you take a look at Rodriguez, you take a look at Hugh Latimer, the various cases that have attracted public attention, they have been strategically chosen, and they have been well told in a way to engender sympathy. So I will leave how did we get there sort of at that level, top down, strategic, change the language and do it through stories. And that hints, I know one of the final questions is where do we go from here? And I'm going to steal my own thunder at the end. We need to tell better stories.
Speaking of the need for better stories, I think what you mentioned about the compassion piece and the intolerable suffering piece that we were, ranting about at the lunch table the other day about the wording of that question. But yeah, it is uncontroversial that we don't want people to suffer. And so I'd like to bring Dr. May into the discussion as a palliative care doctor. You've been working there for many years. You provide care for patients and their families as they're approaching very difficult moments in their illness and the end of life. And so can you speak to what palliative care offers? And can you speak to what it offers that euthanasia and assisted suicide do not offer?
Okay. I just want to take a brief poll among the group here. How many people here have
Watch
had,
your question carefully.
have had loved ones who have been cared for in the context of a comprehensive end-of-life care situation, whether that be at home, at a hospice, or in a hospital setting. Are there people who have had that? That's good. It's nice to see that there's so many hands up. I've cared for maybe 1,500 people in the last 15 years who have died. The vast majority of them are people who have died in their homes. Second to that would probably be people in a hospice setting, and third would be a hospital setting. And I wanted to speak to Ray's point about stories, and just, I have so many stories, it's hard to just pick. And I think one of the drivers of people wanting MAiD is they don't understand how death can actually be for themselves and their families when they're cared for properly and appropriately. So I'll tell a story of a guy who died very recently. He died at home. I only knew him and his family for just under 2 weeks. He was discharged from one of the hospitals near here and told, there's nothing we can do for you, go home to die. They didn't set up home care. They didn't set up any nursing support. They didn't set up any medication for symptom management. There was no doctor involved. His daughter was a patient of mine from a small community clinic that I operate, and she asked if I would care for him. So I made a home visit, and I met him and his family, and he had quite a large extended family. He needed a whole lot of intervention very quickly, which I was able to activate as far as symptom management and nursing support. And then he was comfortable. He was surrounded by his family. He had some ups and downs, and the family needed quite a bit of teaching on how to care for him. And then he entered his terminal decline, where it was clear that he had just a few days to live, which was a surprise that it happened so quickly. So we mobilized more nursing support for him. His family was supported and made frequent home visits, myself and my partner. And he died peacefully, surrounded by his family. I went to the home after he died to the death certificate and all of that, which I have to do, and do a final home visit. And I walked into the home. He was in a hospital bed in the living room. All of his family was around, all of his grandchildren, all of his children. There was a priest there from their parish. The priest was praying a decade of the rosary. Everybody under 10 years, over 10 years old, was on their knees praying with the priest. And I just joined in, and they sang hymns, and half an hour or 45 minutes later, I had a few moments to speak to the priest and just to thank him. And it was absolutely beautiful. And the thing that I'm most pleased about is that every one of the family members got to witness what death can be like when patients and families are supported. So when they approach their own death, they might have a different understanding. I think if you took a poll of the vast majority of people, there are very few people who have witnessed somebody dying. If they have, they've witnessed somebody dying who dies in extremis, whether that be agitation or breathing or pain, so it's very easy for the stories to be told how bad it can be. And people make decisions out of fear. It has been my experience with most people who I probably have cared for 80 to 100 people who have gone on to receive MAiD. I myself don't participate in helping them to access MAiD. I do what I'm required to do via my college in order to satisfy my college requirements, but I don't actively help them to do. There's many systems in place that do that. So I continue to care for people up until the time that they have their MAiD procedure, but I won't abandon them. And it has been my experience that the driving force for much of people choosing MAiD is fear of future suffering. It is an inability to really be okay with what they perceive as a functional decline. Say, for example, they go from being independent to then being bedbound and needing to be changed and washed and have their bottom wiped and by another person. And so many people, if they're projecting ahead in their lives as to how they might tolerate that degree of need, they feel that it would be undignified. They couldn't imagine living like that. They would rather die than have somebody have to wipe their bottom or wash them or feed them, for example. And so it's this fear of that. It's a fear of being a burden on their loved ones. And many people who choose MAiD, I think, are not actively suffering intolerable suffering other than being alive when they don't want to be. So they don't have a lot of pain. It's this fear of the future that's driving them. They don't understand that if they're properly cared for and their families are supported, that it could go okay, that they might choose that. So the problem with offering palliative care as an option and then saying, okay, you can choose palliative care or you can choose MAiD, is people don't really know what palliative care is until they have an experience of being cared for in a comprehensive way. So you can talk about what it might be like, but until they experience it, they often don't know. So to talk to them and say, this is the functional decline that's going to happen, and this is how we'll care for you. So that's one of the ways which I try and allow people to make a completely informed decision, is by outlining as best I can everything that I think is probably going to happen to them as they have their terminal decline, and outline how I'll care for them when that happens, or if it happens, and how we'll support them and their families, so that it takes away some of the uncertainty about what to expect. And I've been a little bit successful, I think, in caring for people who then would choose, okay, then I'll take palliative care as the option I choose rather than choosing MAiD. And that's been a very powerful thing. And I recently had a patient who wanted MAiD because of pain. And once the pain was properly controlled, she wanted to live and ended up dying naturally. So those things do happen. I find it a challenge to practice in an environment where there's a constant encroachment of MAiD into most of the institutional healthcare workplaces, where patients are being offered MAiD without anyone actually trying to understand whether or not their faith might preclude them even choosing it. I had one woman patient who came to me, and I asked what she was most afraid of. And she says, I'm most afraid that you're going to push me to have myself killed. And I said, well, why would I do that? And she said, well, 2 other doctors did that. And she was a Catholic woman, and MAiD was abhorrent to her, and under no circumstances would she choose it. So I worked quite for many years before 2015 and before MAiD became decriminalized, or euthanasia became decriminalized. And I never needed MAiD. I never felt that, oh my gosh, I wish I could kill this person or this person would die. And there's always something that can be done to alleviate suffering. And I think a robust palliative care is absolutely necessary. Unfortunately, it isn't available everywhere. It's patchy. I see you're getting very.
Well, that was
you're
something I wanted
interrupting.
to
You're
pick up on in
interrupting.
your story, because you mentioned the fact that this was someone who knew you personally through your other clinic as your doctor, and so she was able to advocate for access to palliative care. And it seems like, from contact I've had with my own grandmother's situation and such, if you don't have someone who's able to speak up for you, it can be difficult to access some of the treatment you need. And there's so much, misunderstanding about what palliative care is that sometimes it comes in so late or not at all. And I'm wondering, do you feel that MAiD has the part of what we were told was that you don't have to have an expense to palliative care if we advance MAiD? We can do both. Other international jurisdictions have done both. Do you see that we have significantly improved it?
No, we haven't. I think there have been some modest improvements. I think I do believe there's been some resources diverted, especially community-based resources, to providing community MAiD services and that sort of thing. I mean, the home care services are incredibly thin now, and I'm not going to pretend they're not. The family in this patient I was telling you about who recently passed, his probably 10 years ago, I could have got shift nursing for him for 40 hours a week, right from the first day that I saw him, but that's simply not possible anymore. So the family has to pick up a lot of the care, and that includes symptom management and injection of medications. And it's a lot of families going, no way, I'll never do that. But it's actually not a difficult thing to do and to learn. And so there are visit nurses who can come, and myself, I would teach families how to do that. And this is what you do when this happens. This is what you do when this happens. And if that doesn't work, then you call me, you call the nurse, and then we go through a troubleshooting of how to help. So the support, I mean, it's not very good. The kind of palliative care support that people need across the country. It's in rural communities. I mean, we have the benefit of residential hospice here, which is, if you're not going to die at home, that to me is the second best option. They have excellent care. I don't know if I answered any of the questions on the paper.
I can just jump in on this last point. So speaking not here as a policy professional, but this all took place. My wife and I lost all 4 of our parents in 7 years. 2 just before all of this happened, 2 after. So getting involved in this issue was probably as much a personal matter of sorting through that particular process as well. What was interesting, all 4 had palliative support. But the reason is not because it was necessarily offered. The reason is I have an extended family of healthcare professionals who know how to navigate the system. And I was struck very much, as you're saying, it's not just the capacity, it's the labyrinth of the system. If you don't know what's available or how to do that. And speaking of your stories, I was reminded of the story of the passing of my mother, again, when cancer sort of had months to live, and then all of a sudden took a turn, and everybody got that week of that last week of July of 2014 now. So it's this week, almost to the day 9 years ago. It was remarkable. We gathered, one of 4 children. We're not particularly close, partially because of demographics. We live all over the place. We're 8 years apart. We all get along, but that process of that week, which really was a long worship service in which we took turns reading, singing around. We had lots of people come to say goodbye. That remains a highlight, and actually has transformed all of our lives. Of the children and grandchildren, brought us as a family closer together.
So you speak to an absolutely critical point, and it has to do with grief. So much of what is required for grieving happens in that environment you just described, for healthy grieving. And truncating the process by saying, I'm going to be reasonably functional still, and then I'm going to have myself killed, and not allowing yourself to go through that entire dying process, being walked hopefully by your family members. There's healing in those relationships. I mean, I would never say I want people to suffer, but there is suffering. And the suffering is inevitable because there's loss and people are sad that someone's dying. And it's like there's this whole societal aversion to feeling any kind of suffering, any kind of sadness, any kind of difficult emotion. But those are absolutely critical for preparing oneself for the death of the loved one and going on living after. And we're robbing families of that experience. And I think it's just awful, because then when they come to their own deaths, they're not going to be prepared as they would have been if they had witnessed and walked with their family member dying.
Speaking about the inadequacy of some of the palliative care systems, unfortunately, another area that we have seen inadequacy is in mental health services, particularly among certain marginalized and vulnerable populations that, again, maybe don't have someone to help them access the counseling or the medication or the doctor's appointments that they need. So Dr. Tang, as a psychiatrist, you testified before the Senate and you've spoken out about your concerns about the expansion that is impending next March 2024. It was supposed to be this past March, but thankfully we had a delay of 1 year. Now with this upcoming expansion, what are your concerns as a psychiatrist, particularly as someone who has been an advocate for those populations that don't always have access to that care?
So I think very simply, my concern in a big picture type of way is that we are going to be intentionally putting to death people who could have otherwise recovered and gotten better. The problem of expanding euthanasia and assisted suicide to including mental illness is that there really is no consensus right now within my profession about how do we accurately identify someone whose mental illness is irremediable. When the whole process has been terribly flawed, the process of how we got here. When the original law came out with Bill C-14 in 2016, one of the safeguards was to relegate euthanasia and assisted suicide to end of life. And so by virtue of that, most people with mental illness is not going to die of their mental illness. But since Bill C-7 came, and even in that process, originally Canada, the government of Canada, said that we would not include mental illness as a eligibility criteria because of all the complexities that we recognize in this type of population. However, they did a complete about-face, mainly due to pressure from the Senate. There was very little time for debate. When we started the debate with Bill C-7, mental illness was not on the table at all. But then there were talks within the Senate saying that if we didn't expand euthanasia and assisted suicide to include mental illness, this would be discriminatory against patients with a mental illness, and we should treat them the same. They should have the same kind of access. Well, here comes the question of the difference between equality and equity. And I think what they're trying to do is to treat everybody equally. But it's a recognized fact that many of the patients that I treat are disadvantaged, and just giving them equal access to a procedure that is going to terminate their life is actually discriminatory towards them. And so the difference between equality and equity, it's like, I'm probably the shortest person here, but if we were all to stand up and there was like a fence, like a really tall fence, and I wanted to be able to see over that fence, which Andrew here might be able to do fairly easily because he's much taller than me. Well, if we were to treat all of us equally, I could have maybe a step stool and he would have the same step stool, but it's still not high enough for me to see over the fence. But I'm being treated equally. We're giving everybody the same height of the step stool, but I am at a disadvantage because of just my makeup. And so that's what we're seeing with people who have mental illnesses. You're treating them the same, but equity is giving them equal opportunity. And oftentimes my patients do not have these equal opportunity. And when euthanasia was relegated to end of life, what we saw were the people who chose to end their lives prematurely were those who were generally rich, kind of powerful. They had lived their life in total control of their life, and they wanted to control their death as well. But now you expand this to those who are not near death and to people who are living in poverty, and you're giving them the same option as well, without at the same time providing them the degree of care that they would need. Moreover, the patients who are requesting euthanasia and assisted suicide don't even need to be able to access the treatment that they require. So, okay, there's just so many problems with this. Like, where do I begin, right? But within the legislation and the new recommendations by Health Canada Model Practice Guidelines, they recommend that the patients have to have a conversation with their psychiatrist or their physician, who, by the way, also, there is no requirement for like certified expertise. So right now you could have a physician or a nurse practitioner to be the MAiD assessor. So really what you could have is a nurse practitioner who hasn't gone through the 5 years of psychiatry residency program, who has worked with mental health patients, and they might be deemed qualified to have expertise to make this determination. There's really no strict, concrete guidelines. Everything just seems kind of very wishy-washy. But going back to the whole eligibility criteria, the patients can decline to take treatments if they don't feel that it's acceptable to them. So, you know, this came about through people who are maybe at end of life, who have cancer. They want to decline chemotherapy, and so they felt, okay, that would be reasonable, and they could still access an assisted death. However, in mental illness, most patients they can go on living for years. And so technically, what do you say to a patient who maybe they ticked off all the check boxes, but maybe they haven't tried ketamine, which we know has evidence for, you know, treatment-resistant depression. But even if they wanted to have the treatment, but say they're just too poor to access it, because ketamine now is a fairly novel thing. If you don't have insurance, it can cost thousands of dollars for the treatment. So it's not accessible. And you know, if I was a patient and I can't pay for it, well, now the government is sort of spinning it as if you don't end their life, you are just kind of trapping them in the situation where they're poor, they can't afford the treatment, and so you're kind of trapping them into the state of suffering. And the more compassionate thing would just be to end their life. That is a very twisted version of healthcare. I've never seen anything like it before. Also, I also question why we are making this into a medical issue, because for most of the reasons why people want to end their life, it's like existential questions, loneliness. A pill is not going to solve that. If the solution is not a medical solution, like, you just need a friend. You need somebody to come here and to support you and to encourage you. Why are we looking then to the medical profession to provide a medical solution to a problem that's not really medical, especially for mental illness, right?
Yeah, and something that I find very contradictory is that there has been so much of a public push for better mental health awareness, that we want to reduce stigma. We have Bell Let's Talk Day. We have all the posters on the subway walls about, you know, if you're feeling like committing suicide, here's a number to call. We have this whole public concept that when someone is suicidal, we want to prevent their suicide. We want to, because we recognize that they could live a full life if they can access both the medical and the psychosocial supports that they need. And yet, on the other hand, so the government is committing to, we're going to expand mental health access and awareness and all these things. But on the other hand, we're going to expand death for those who are having mental illness as their sole underlying condition. And so as a psychiatrist, how is this going to impact your ability to treat patients? And are you already seeing that kind of impact?
So suicide prevention, I think, is going to be even more difficult to do now with this, because one of the main ways to prevent suicide is preventing access to lethal means. Well, what is euthanasia and assisted suicide, now otherwise known as medical aid in dying? We are facilitating suicide. I mean, if a person is trying to end their life, that is by definition, a suicidal intent. And what's interesting is that when the Carter case came out, the judge actually said, we are not, like, the facts of this case does not look at mental illness. And they also, I think it was the Truchon case, they're saying that doctors are able to distinguish between those who are suicidal and those who aren't. And so we're only going to give medical assistance in dying to those who are not suicidal. And furthermore, in jurisdictions where we have legalized these procedures, it has not increased suicide rates. But now new evidence has come out, I think, in a recent study by David Jones, an Oxford scholar. He showed that in jurisdictions where they have legalized euthanasia and assisted suicide, suicide rates have gone up. And so there is something called suicide contagion. So I'm very concerned about how the change in this culture is going to affect how we see suicide. And so now the language has even shifted. People are actually acknowledging that medical assistance in dying is a form of suicide. Thank you for acknowledging that. But we started off with saying, we're not endorsing suicide. We can clearly differentiate. And even some of the experts wrote in the expert panel that in some cases, medical assistance in dying is indistinguishable from suicide. Okay, so right now what we're actually talking about is an entire government culture endorsing suicide as a response to suffering. What kind of messaging does that provide to anybody who's alive and breathing? So right now, if a patient comes to me and they're suicidal, the law gives me authority to bring them into hospital, even if they don't want to, because we recognize that in that moment, they actually need somebody outside of themselves to protect them. And so we bring them into the hospital, which is supposed to be a place that's supposed to, provide them with care and support. Now, the entire system right now is geared towards preventing suicides. When we allow this for mental illness in 2024, I'm not going to have any more legal power to say, I can't help you end your life, because my role as a physician and as a psychiatrist is to enable you to continue living, to pull you back from the precipice and give you hope and get you better. And now the government is saying to the same psychiatrists that they expect to help prevent suicides, to say, it is now your job to figure out who should live and who should die, and to facilitate that. And what we're going to see is that those who are most marginalized, the poor, people who are discriminated against, who don't have equal opportunity, are going to be the ones lining up to have their lives ended because life had treated them so poorly that they have not been able to receive the care and the support that they need. And they see that as an exit. And for me, that is a huge societal failure on how we as a society has chosen to treat those who cannot help themselves, and to endorse this at the level of a government. there's something that is terribly immoral with the direction that our government is taking our healthcare system.
If I can just pick up on your last comment in terms of a failure of society and it being immoral, take it back to the language conversation that I had earlier. It is interesting, you know, your complete litany, and you could go on for a whole lot more with a whole lot more contradictions that are just inherent in the way this is being rolled out. I'd reference, for those of you who are interested, I don't want to turn this into a deep philosophical piece, but it seems the right time to raise it now. David Brooks, in the June issue of Atlantic Monthly, wrote it's a cover story on Canada's the imposition of euthanasia in Canada, but he uses it as a case study to ask whether this is a logical consequence of liberalism and whether or not just inherent in a liberal society without any religion or purpose or sense of the common good, when liberalism is simply a set of democratic processes but not oriented towards a consensus about what is actually good, you end up with this as almost a logical consequence. And as you were saying that in terms of a failure, I'm not here to defend the other side, but if I were on the other side, they would respond to what you just said. It's actually not failure, it's success. Because the greatest good in society is autonomy and you choosing. And you're choosing your own death and controlling the circumstances surrounding your own death is a greater good, if that's what you choose, than the circumstances. So there is a perverse law. I don't agree with that logic. And I would respond, even if you are right, you have just introduced your own morality, and I thought we didn't have civil religion in Canada. But there is actually a certain logical consistency about which reflects this as an ideology that's being driven, and one doesn't have to go very far beyond the PR lines in terms of, oh, of course we support your choice and palliative care and everything else, and no, we won't take any resources from it. The reality is, when you take a look at the medical system as a whole, I found it very interesting that during the treatment of Bill 7 over the course of the last year, the Parliamentary Budget Office did a calculation as how much, if the expansion of MAiD was going to happen, how much it would save the taxpayer. Well, wait a minute, since when is that calculation even relevant to the discussion? And yet our parliamentarians were being provided by this service. I'd still be very interested in who initiated that particular study and report. It also, tying this back to the language, I'm all in favor of medical assistance in dying. You may have noticed various of us tripping over the language. Because what we're really talking about is not medical assistance in dying. Medical assistance in dying is what you do every day. Okay, you use the technologies and the wisdom that medicine has provided to deal in the dying process, alleviate the pain and suffering, and manage it. You assist in the natural dying process, and I'm all in favor of that. The problem is what is euphemistically called medical assistance dying is medical intrusion into the dying process. It's medical assisted death. It's not in dying. It's causing death and not assisting you in dealing in the natural dying process. And there's a host of consequences. But anyway, I thought it was important just to highlight that. And as I said, that's a whole other panel discussion. And we maybe need a 4-part summer series to deal with that. But David Brooks in the Atlantic in June, if you want to dig into that, it's a fairly lengthy essay. I had the opportunity to work with David a bit in preparing that essay, but I think he does an excellent job in terms of framing this, not as a process or a healthcare system, but a much more existential thing in terms of what liberal democracy is ultimately.
I think, Sephora, you wanted to jump in on the autonomy question, and
Yes.
then we'll let Dr. May comment.
If I could just respond to that. So choice and autonomy, I would just question whether it really is a choice. If you are in a burning building and your two choices are to stay in the burning building or jump, if your decision to jump to your death is the decision that you take, was that really an autonomous free choice? And this is the question that many of my patients are going to be facing. Do I want to stay living in poverty where I can hardly make ends meet, end up homeless on the street? Or do I take this exit where somebody can end my life so I don't have to face that kind of a future?
And we've seen cases documented in the media of people asking for and being granted MAiD specifically for situations like that, where they have particular housing needs and those aren't able to be fulfilled. And so, they can't get the ramp that they want for their house to have basic accessibility. So they're being offered medical assistance in dying instead.
Can I just also follow up on in terms of wait times? So for track 2 cases, which are those whose deaths are not reasonably foreseeable, there's a 90-day waiting or like an assessment period of 90 days. Well, in some regions of Canada, like in New Brunswick, the time it takes to receive psychiatric treatment, just to get the treatment going, is 4 times that 90 days. And that's not even just going through the treatment, because sometimes treatment like psychotherapy, for example, could take years, right? So how do you reconcile the fact that the assessment time is only 90 days? And then for track 1, people whose deaths are reasonably foreseeable, they actually haven't defined what reasonably foreseeable means. So that's another huge problem. But that is significant because if you are deemed to be track 1, where your death is reasonably foreseeable, there's no wait period. It used to be 10 days. And then they, with Bill C7, they said, well, people who opt for this have already really thought about this a lot. And so that those 10 days are just an extra 10 days of agony. So we'll just get rid of that. So if you're talking about somebody who's maybe, let's just say 85 years old, and their time span looks limited just by virtue of their age, which I will say is ageism, and they also have a depression, they've declined treatment, they don't want it, or maybe they just can't afford it. Technically, under the law, they could get that if 2 assessors say that they qualify, and because they're 85, their death is reasonably foreseeable, so we don't even have to wait the 10 days to make this decision. That is how lax the law is right now. And this is the framework that we're going to be operating.
And it's not just the law. I've spoken to palliative care doctors who have told me that they have witnessed cases from the request to the administration in just over 24 hours.
I think on the palliative care note, we'll let Dr. May jump in.
I just wanted to pick up on something that Dr. Tang said around the culture and what is going to be expected, because increasingly there's less and less space for people of conscience within medicine. It is now becoming the expectation to offer MAiD if you think it's appropriate. So there's a whole cohort of young doctors coming through now who have gone to medical school and done all their training within the context of MAiD being available. And it's becoming normalized. It's becoming expected. It's, when you go to the emergency room and somebody goes over all your treatment options, now one of them is, if you fit the criteria, is going to be, would you like MAiD? And I think and I suspect it may be going to happen in psychiatry too. When your suicide patient comes in, you can say, well, you don't have to have suicide. You don't have to suicide. We can offer you assisted dying instead. So I think we're doing a real disservice to people, and the whole, like, what does that do to the heart of medicine? I cringe sometimes, and there are some days when I'm really kind of grateful I'm towards the end of my career, because boy, it's going to get so much worse, I think, in the coming years. I really do.
I just want to follow up on what you said. It's not only if you think that assisting their suicide is appropriate to offer it. Now, the recommendations are, if you think that medical assistance in dying or euthanasia-assisted suicide is in line with the patient's values, which you're supposed to somehow assess, then you have a duty to inform them as part of informed consent. They need to know what all their options are. So you can imagine the conundrum that could arise if a patient is depressed and suicidal. I mean, just to say, like, okay, Dr. Tang, you need to tell them that you could also facilitate their suicide. And I'm just like, yeah, but they're suicidal. I'm trying to, it just doesn't make any sense. I'm trying to save this person's life, and then expecting me to say, oh, by the way, this is also an option that you can have. It's just completely incongruent. And I I do cringe about the type of care that our loved ones are going to get when they go to a hospital and they are in a state of distress. What kind of doctor are they going to encounter who will provide them care or not?
And unfortunately, I think with this topic, we could express a long list of all the contradictions and all of our fears about the future. But I would like us to have the opportunity to say something that we can do. Like, what can the people in this room do about this? Even just the smallest thing, from the perspective of those who maybe work in politics and policy, from those who are maybe in the medical field, to just those of us, which is all of us, who have loved ones who at some point, and ourselves at some point, are going to face issues of illness and death and dying. How do we respond to these issues in a way that meets the challenge, but also that we don't despair and become despondent and just give up? That's for everyone. It's an easy question, I realize.
Shall I go?
Go for it.
Okay. That's a very good question, because there are a lot of things allied against helping people make life-affirming choices. I think with March 17th, 2024 on the horizon, that, it might not be a done deal that it's going to be actually put into effect that day. So those of you in politics, or have some seat at a policy table, or know somebody in the Senate, or want to write letters or talk to your MP, just to let them know that that this is not okay, that this is a mistake, that we need to be offering people life-affirming care and mental health help, rather than pushing them towards having their lives artificially terminated. I do think those of you who know what palliative care is, can advocate for your loved ones with your doctors, and keep pushing them and saying, this is what I want, this is what I want. And because it is available, but I think that, like Ray was saying, the system is just so complex. And I've worked in it long enough now that I know where to apply the pressure in order to get the desired result. But that's taken years of working in multiple different settings, in acute care, in the community, in the hospice, in chronic care. So I know how the system kind of works, and I know who to call. But I don't think there's a lot of people that actually know how to do that properly when it comes to palliative care. In Ottawa, we're really blessed with certain community palliative care providers who do home visits exclusively. So those are people to try to access. And I think ultimately that we also need to be creating sanctuary spaces for ourselves where we can, and that's one of the things I'm trying to do with this clinic I'm running. It's aligned with our principles with Christian faith, and there's a groundswelling of community support, and we're caring for 600 people now, I think, and it's going really well. Yeah, I think that's it.
What I would say is, just like you are doing tonight by coming to this talk, is getting informed and talking to people about what you find, because what you're hearing the politicians say when you hear Justice Lametti say that this is a former, yes, he was reached up, former.
We're a nonpartisan think tank, but we did notice that.
Yes, that's right. Well, we'll have to see how the new one does. But anyways, when you hear the politicians say that this was a very well thought out decision, that there are safeguards that work, I would just look at that very critically and ask yourself, is that actually true? And don't just swallow what they're giving you, because if you actually read the guidelines, there's a lot of gaps. And I had shared some of those with you today. if you do get the book, chapter 17, I co-authored, I've laid out many of the concerns in a lot of detail. And just look up the Health Canada model practice standards as well. They have some advice to the profession, addendum, documentation that also gives recommendations that are, questionable. But after being informed, then I would really encourage you to contact your members of parliament to change things at a federal level. Right now in the fall, I think we are still building up momentum to potentially be able to push back the rollout in 2024. We're still hoping. I mean, now that the secular media has caught on to the story and there are more and more news stories describing the concerns about this expansion, I think it's actually making some members of parliament, especially within the Liberal caucus, a bit uncomfortable. And so we want to keep that pressure on. Ed Fast has a bill that he's introduced to undo the whole expansion to MAiD for mental illness. So even if you were to write to your own member of parliament to say that I would support Ed Fast's bill and just to express your concerns about the expansion, your MPs, if they're doing a good job, they are supposed to listen, although there's the whip. But I think as long as we keep speaking out and we don't just become complacent and say, well, it's going to go ahead anyway and just kind of give up, I think there is still an opportunity for change. And then at a provincial level, talking to your members of provincial parliaments, because healthcare is provincially regulated. And so what we're seeing now is the government imposing itself onto faith-based hospices, for example, and forcing them to do euthanasia on site, even if it goes against the mission and the values of their founders. And I think, as Dr. May was saying, it's really important, especially in this context, that we have sanctuaries, safe spaces that we can go to, me, you, your loved ones, and be assured that their doctors are not going to put an assisted death on the table as a treatment option as part of informed consent. I think, like, looking at the Indigenous populations where their suicide rates are just, sky high, I think that especially under current circumstances, having these safe spaces for healthcare is something that we should be able to demand. Just because the government has a responsibility, if they want to allow for medical assistance in dying as a medical act, it doesn't mean that every hospital, every hospice needs to provide it. Where is the choice that we want to have life-affirming care that is safe? And I think we need to let our politicians and our leadership know that this is something that we value. The Catholic hospitals that we have who are already doing life-affirming care, we want to protect their ability to continue doing that without being coerced to go against their values. And I think that it's voices from people like yourselves sitting here tonight that is the most powerful. Grassroots advocacy can do a lot, but you just have to kind of be coordinated, know when to act, not look like you're all lumped together in one group. So it's better if you look like you're all kind of separate and there's lots of people voicing similar concerns, but they're not, formally connected. That can help. And then finally, I would say building healthy communities. Our society these days is sending messages that is kind of contradictory, that puts our loved ones at risk. And I think if we can build communities where we are actively supporting each other, you look out for your neighbor, you try to help people to become inclusive and cared for, do home visits, outreach, so that people are not placed in a situation where they feel like they have no other choice but to end their life because they feel like nobody actually cares about them. And then I think also continuing to advocate for increased social supports for people who are living on the poverty line. Like now it's just really hard to live on Ontario disability support. But what about trying to change work environments that are a bit more accommodating to people who have disabilities or mental illnesses, to be a bit more understanding, so you can actually help people to earn a livelihood if they can, but be understanding in providing those environments so that we can build a society where we can thrive together. I think that's all I have to say. Thank you.
And Ray, I'm going to add on to your question because, where do we go from here as lay people, but also you happen to be the vice president of a think tank. So where does Cardus go from here as well? What was the impetus behind starting Cardus Health as a way to speak to some of these issues?
I'll end with that. Let me just start personally, and I agree with much of what I said. Much of what I'm going to say can sort of overlaps very much with what you've just heard, but let me just tell you the story in first person terms, in terms of my own community. Number one, I already shared the story of my mom's death, and I could multiply that by 4 in terms of all 4 parents over the last years. They're different, but what is striking is they all tell the story that death is not a personal matter. When we're told this is all about autonomy and individual choice, but when a person dies, there are at least 5 people on average, the data tells us, and if you come from a Dutch Reformed family, there's many more than 5 people who are directly impacted. Their lives are permanently changed. The death of a person doesn't just affect them, it affects the people immediately around them in a permanent sort of way. And that can be actually a very good way when you're able to share the sorts of stories that we were able, and I consider it a blessing of God that we were able to do that. I understand that's not all within our control, but some of it was because there were proactive steps that were being taken along the way. So number one, tell your own stories. Let's not privatize death. Let's understand that death is a shared event along the way. Secondly, in my own church community, as a result of the fact that we have a demographic not unlike myself, in which there are several of us who have gone through this process. And I've seen in other families where they did not know how to navigate the health system, much sadder stories. We in our church, and the church I'm a member of in Hamilton, together with a few others, are just in the process of forming an organization right now in which together as churches, we are hiring a couple of nurses. And they are going to be available to all of the members of our church to accompany them to doctor's appointments and to help navigate the system. So we are viewing that as a ministry of the church, and we are going to start for our own members, given our own demographic and where we're at. But once we do that, we're also seeing of trying to make those resources available to the community. That brings to the very next phase. We're in the midst of, the Dutch Reformed community has several long-term care facilities. We're in the midst of it. We've just merged 3 of them, and we're building a huge campus of 20 some odd. We've just raised 20 some odd $1 million. It's a $200 million project in Hamilton, which actually is going to deal not just with long-term care and residency, but also is looking at hospice, support for home care, sort of the complete continuum of care that we're trying to work within. So that we haven't got to politics yet. This is each of us in our own communities with our own networks can tell those stories, can encourage those that we're in relationship with, can share the expertise. If you don't have it in your family, I'm certain that the nurse who is a member of your friend's family is happy to help. And then as we build to churches, we can build some of that community. The point I would make is let's not just look at government and politics. We'll get there in a minute, but that's actually not the immediate solution. And I actually think there's more power in grassroots activism in the day-to-day dealing with this issue that actually, when it's done well and modeled well, our neighbors will see it, they'll want to participate, and that entire thing will create a political dynamic and political pressure that the politicians will always hear. I've been doing politics in one way or the other for the last 20 years at Cardus in a nonpartisan way, but prior to that to a partisan way. And let me share you a secret that I've learned along the way. Politicians don't lead, they follow. They follow what they hear in terms of what's out there. And when there's enough of grassroots activism that experiences this different and does this differently, the politicians will hear that sound. That doesn't mean we ignore politics in the meantime and everything that was said by all means. Let's go forward. I'm very much with you. I don't think March of next year is necessarily a done deal. I think there are lots of reasons. That said, who knows? There are political forces along the way. I frankly don't see this as an election winning issue for the Liberals if the stories manage to get told in which this is becoming a cop-out way of not providing palliative care and social services and everything else. But that actually means that we need alternatives that talk about the healthcare system in terms of, you know, we can deal with it on the supply side. We can also deal with it on the demand side. And, you know, here at Cardus, you know, our support for the recently passed disability bill and some of that isn't part of the healthcare program, but it has everything as much to do with this issue, as you just highlighted, as the program that we have for health. But I am excited to say we now have a full-time person dealing with health at Cardus, and I'm not just dealing with this from the side of my desk. There are really, as we look at this, there are sort of a number of themes that we hope to achieve with that. One of the areas is aging and dying well. And by that, we don't just mean dealing with MAiD. I don't know about you, COVID exposed for many Canadians the state of our long-term care facilities, and they're not pretty. Prior to Cardus, I worked in that sector. I've only carried a picket sign one time in my life. I'm not a natural protester. I feel very uncomfortable. But in 1993, I addressed a rally at Queen's Park dealing with the inadequate funding for our long-term care facilities and the squalid conditions that we put some of our seniors in. Now, it's by that I don't mean every nursing home and is squalid. Don't misunderstand. There was a lot of very good work and a lot of very good homes, but there are a lot of problems in how we fund, govern, and deal with our healthcare, long-term care system. So we are looking at aging and dying, not just from the narrow policy perspective of medical assistance dying, which is the issue du jour, but from a larger framework along the way, including how those are provided, palliative care fits into this, where does that fit in, what sort of resources. So we'll be doing a number of projects, auditing and working in partnership with others. We don't intend to replicate the good work that many other good organizations are doing there, but we have identified various gaps that we think are there, and we think we can collect some data that will help us tell stories that actually will advance the cause. So that's the one area. Another theme that is there, and we've done some work at Cardus on this already, but we're putting it into the healthcare, deals with social isolation. For those of you familiar with Cardus, you know that we talk about our imagination for a thriving society, and we do so emphasizing the role of all civil society institutions. Government's not the answer to everything. And you know, you mentioned earlier on in terms of people who are suicidal because they don't have relationships and they don't have support. We did a poll, I believe it was 2018, which looked at categories of social isolation. And lo and behold, it wasn't education, right across the education from high school, from those who dropped out and didn't have a high school diploma to PhDs. We were seeing representation significantly in every spectrum of the I'm feeling isolated from the very extreme on one side to the other. Didn't matter
I can
whether
confirm that PhDs do result in social isolation.
Yes. So there's a caveat actually that we did not properly see. That's why we hired you to do quality control. So the next edition is going to be more nuanced. Income, education, none of those are really significant factors in determining the distribution. What are two factors is, were you an active member of your faith community and the state of your family in terms of those relationships. Those were the two areas. So part of our health, one of the things at Cardus is that we focus, you know, we have a work in economics, family, health. We have 7 different programs, but we emphasize the interrelationships with them. Part of the problem is sometimes in society, we try to deal with each problem as an isolated thing and a checklist, but they are so interconnected. So good family policy is actually good policy that deals with this. Played a very minor role in this, but was very pleased to be part of the lobby back in 2015, 2016. I don't remember exactly when, to see the definition of compassionate care for taxes change from 6 weeks to 6 months. So if you have a terminal diagnosis for someone in your family and you need to take off of work in order to care for them, it was only 6 weeks. It is now 6 months. What does that do? It facilitates the family structures from doing and providing the sort of home care that you talked about, which and when it was 6 weeks, often was not financially affordable. So there is a range of policies that are there. I guess the bottom line I would say is start at home, tell your own stories, build supports for you and your family and the communities that you are in, and then go out from there. And then for those of us who are more, all of us are as citizens are involved in the political process, make an election issue, raise it, make sure you tell pollsters about it when they ask you, write letters to the editor, write to your MPs, be loud about it, and tell your positive stories. And
So Monica has strategically made her way to the front of the room to signal to us that it is time for the Q&A period.
I will give you the mic, so I'll stop it.
So I would invite you, Monica will circulate with the microphone to make sure that everyone can hear your question. You may pose a question to the panel as a whole or to a particular panelist. And I'm sure that we can pick up on many of the themes that we've been talking about over the past while.
Hi, my name is Trish, and I actually work in healthcare. I work in home care for post-stroke adults in speech therapy. So I can see a lot of need in, that's not palliative care, but anyway, in the healthcare field. Question along the lines, Dr. Tang, you were talking about, but for the whole panel, it just seems fascinating to me that there's not sort of forward thinking about the repercussions of what could happen in March regarding mental health, because if we're not grieving in a healthy way and we lose, like you had mentioned, the 5 people at least that are involved when someone dies. So if someone that you love chooses that, I can only imagine the repercussions of multiple people. And then like, look at our system going forward. We're going to have more mental health issues. We're going to have more suffering, like beyond what you can imagine when you lose someone who has chosen to end their life. So I just wondered your thoughts on where is that forward thinking in terms of how is this a solution? It's going to just like plummet downward, and especially in the mental health area. I can't even comprehend how that makes any sense to help people at all.
I don't think there was a lot of forward vision. I think that's part of the problem. But their solution would probably, well, if we're going to increase mental illnesses because of this, well, then we have a solution for that too. Right. There's our human. Yeah, and I think that, you know, the pendulum is swinging so far in one direction. I'm very hopeful that at some point it will eventually swing back the other way. If all the people who are pro-death eventually self-annihilate, then, you know, the people who are left. I mean, is that not the natural progression? But my concern is actually that society will be changed so much that this is becoming so normalized. You know, when we had Bill C-14 and euthanasia was at the end of life, it was limited. But now it's open up to anybody above the age of 18. They're thinking about extending this to mature minors. So the entire population is going to be affected. Oh, there's a lot more people now at the end of life who are choosing a medically assisted death. But what, as you say, like, what does this mean then when this can be opened up to any age now? I think the population will probably start going down. Yeah.
So I can speak briefly to that as well, Trish. Thank you for your question. I mean, it's already happening with the mental health piece that you talked about, because, I mean, if you think about a person who is profoundly depressed, who has reached the point where they might choose MAiD or assisted death, I need to get the language right. You know, the likelihood is that they come from a family where there is also mental illness. You know, as we know, it's not that that person didn't grow up in isolation, and so you're already dealing with people who are broken, and now one of their loved ones has chosen assisted dying. I mean, to me, it's just mind-boggling. Suicide needs to be hard, and it needs to stay hard. But clearly that's not the vision of many of the people making the rules.
Hi, my name is Amanda. I work as a chaplain, but I'm also a registered psychotherapist. And this week, my college regulatory body actually emailed all the psychotherapists in Ontario and asked for our views and a long survey about MAiD and with the upcoming changes and like whether we, would ever support it, do it, what would be some of our concerns, professional or personal. So I was really glad that this was happening this week because it's giving me a lot to respond to in the survey. And one question I had was, I think Sephora, you mentioned, it's as if the government's spinning that if we don't end someone's life, you're trapping them in a state of suffering. And the more compassionate thing would be to end their life. And I think to all of us here, it's obvious that that's twisted, as you said. But how would you respond to someone who sees that as logical? How would you kind of, problematize that?
Like to like a patient themselves who is wanting?
More to someone endorsing it at a policy level, I think, or people making decisions,
Yeah.
like my college.
Well, I would just point out the discrepancy there about, as a healthcare professional, I'm supposed to be somebody, like my role is to help support others to live, to enhance their lives. And so actually ending their life is completely contrary to that. And I'm not going to be boxed into thinking that if I can't, if I'm struggling with providing care for them because of all of these social issues, that the only compassionate thing to do is to end their lives. I think we need to just highlight that that's just really incongruent with my role as a healthcare professional, and to get them thinking that, death is not the only solution. So why are you thinking that way? Just don't accept the status quo.
And I think it's a twisted version of compassion, and the government is passing the buck on their responsibility. And if someone says the compassionate thing is to end their lives, the answer is no. The compassionate thing is to care for them and support them and provide them with adequate housing and provide them with a living wage and all the things that are actually systemic problems that have caused the person to be trapped. It's like, it's not you that's trapping the person, it's the government and the way they've not supported the person that's trapping the person, and point the blame and the responsibility to where it's supposed to be.
And where would be the impetus then to improve our social context then, if the easy way out is just to end people's lives? What is the impetus to then improve living situation for people, to, clean up the long-term care homes and ensure that that's actually a dignified place for our seniors to go?
I think just to add one thing, and how you actually communicate it is very contextual. So I'm not suggesting you use the words I'm about to use. It really depends on who you're talking to and what. But I think there's a basic category problem that logic is there. And you can, I think, even talk in total secular, non-religious language and identify it for most people, because the assumption there is that the purpose of life is pleasure or the avoidance of suffering. And we define the utility of life entirely in terms of either obtaining pleasure for yourself or avoiding suffering. And the minute that's not there, there is no purpose for life. Most people, I think, when you actually frame it in an appropriate way, would actually, do you believe that you are on the world to do good? And most people would assent to some version of good. Now, without getting, obviously that's a religiously, the conceptions of the good very much depends on our own conceptions of God. But even at a purely non-religious level, do you agree then that, your being alive may be good for others, may be good for your family, may be good, move it away from the total personal pleasure, pain dilemma to good, which is by definition social. And if you succeed in changing that frame, now you at least have a basis in public conversation. But when we give up the language of good in any way and have it entirely about autonomy, suffering, and pleasure, they've won the argument.
Hi, my name's Megan. I'm a freelance journalist. Apologies on behalf of my industry for completely watching this story for decades. I'm also legally blind, so I would meet the medical definition under track 2. You mentioned this came up in passing in one of your answers about mature minors. I was just wondering, for people who may not be as versed on, for example, the MAiD committee report that came out earlier this year, that type of thing, like what else is Canada possibly considering beyond expanding for the sole purpose of mental illness?
There are several things that are sort of commonly discussed. Mature minors. So at what point does that decision make? Then who makes that decision, and how is that determined? Advanced directives is another very significant conversation. So should you be allowed at this point of your life, in the same way as you might have a do not resuscitate form, as part of all of that, could you say, well, if these circumstances, set of check boxes are there, I want MAiD, and if I'm not able to make that decision myself at that time, this is what I want. Obviously, all sorts of questions come because we're dealing with hypotheticals in the future. So there's lots of judgment involved, who makes those things, but that's also part of the conversation. I really, sadly at this point, when I follow Dying with Dignity's website and their PR, as I'm sure you do. And sometimes it's pretty frightening, actually, the callousness and the directness for those who are insulated from this and, sort of assume goodwill on everyone's part, and the notion that we all want everyone to live. And, I stumbled on the street the other day and there were 3 people around immediately wanting to help me in that. And that reinforces my confidence in society. But when I read some of these organizations, it feels like the death of more people is something to celebrate. And they're looking for means to equip that. So I think, almost everything is on the table to some extent. I don't think politically, right now it's the mental health thing. And I actually do concur that, if it's played right in the public square, and by that I don't just mean the politicians, I mean all of us who help shape the media conversation, the public conversation about it. I think there is increasing pushback based on some of the abuses, in addition to the abuses that have been in the media. One of the things I've put in almost every piece that I've managed to write about this is the fact that the United Nations Special Rapporteur on Disabilities and Human Rights, before the second piece of legislation, after the first, highlighted the lack of protection for vulnerable communities in the legislation. Now, ordinarily, when the UN says something that Canada is not following UN guidelines and all the rest, there's a bit of consternation about it. We usually take what the UN says pretty seriously. Well, the UN is critical of Canada's protection of vulnerable communities in our legislation. And that was before we loosened it. So we need to tell these stories. We need to get them there, because I think there's probably a third of Canadians that are ideologically on this issue and really pushing it. They're controlling the narrative right now. We've got to get the rest of us need to get to a narrative that actually will appeal to the 50 to 60% who actually may be okay with MAiD, but are very concerned about the supply factors and protection of the vulnerable.
My name is Roger. I'm a retired teacher. I'm also a member of the local Anglican church. It seems that the churches have been strangely silent on this whole issue. What advice do you think you could give to the churches on what we should be doing?
There was an excellent article that was in Plow magazine a few months back on that's an American, it's an American journal, but they talked about Canada and the complicity of silence of the churches in this whole documenting and having gone through the various churches and their statements. It is, of course, challenging to talk about the churches generally, because that has a pretty wide swath, and there are significant exceptions in First of all, only 12% of Canadians attended a place of worship in the last 7 days. About 6% Catholic, about 5% Protestant, 1% everybody else. Then that usually comes as a surprise, including Muslim attendance, less than 1% of the population. So we're dealing with 88% of the population who are not part of churches. And ironically, if you are born after 1965, 2/3 Canadians have never attended a Christian worship service apart from a wedding or a funeral. They don't know even what a church is. So I say that as an elder in my church and a leader in my church, not because I want to diminish the church, but the church isn't, in terms of its cultural weight in society, it even doesn't have great cultural weight even among its own constituency. So I put that caveat there. That said, I would say, it starts with members of the church challenging their own leadership where there is silence. It is a divisive issue in some churches in which increasingly I have read reports to pastors that have not talked about the issue, but entirely in terms of how to pastorally support those who are dealing with MAiD, and have ducked. That's where they enter the conversation, not about the rightness or wrongness, but an acquiescence to it. I have my own thoughts about what sort of theology leads you to that conclusion. The problem isn't a tactical one in many churches. It's their commitment to some principles. And as I said, that can be misinterpreted as a sweeping statement. There are bright lights in denominations right across the spectrum, and there are horror stories along the way. And I'm not sure if you have the wonderful answer in terms of how to address it all. I'm all ears, but it is more of an observation that reinforces the premise of your question than it is a real answer.
So in response to that question, I think, as Ray was saying, it is a very divisive and polarizing issue, and there is not uniformity even amongst the Christian faith communities. I think church leadership is put into a difficult situation, and we would like our church leaders to be able to have a firm stance on something. But honestly, I feel like on this issue, it's going to have to be the members of the parishes, the congregations, the church communities to be the ones to speak and say, this is something that we have concerns about. So maybe if you have something from the top and the bottom working together, that might help. But if we're on this topic about churches and how they might be able to help, I think really as Christians, going back to what you're really good at, like praying, what is manifest in the physical realm is simply a reflection of what's happening in the spiritual realm. And I think right now, this is not a time for division. Brothers and sisters in Christ of all denominations need to come together in unity. And there is power in praise and worship. If I think that this is primarily a spiritual battle, because given how much we've been trying to do, at the political level and how much resistance we're getting, it can get kind of tiring. And I think that there is another level of resistance that needs to be overcome. And maybe what Christians are failing right now is in that primary duty of preparing the spiritual environment in order that the efforts that we're making at the human level will be able to bear more fruit. So just remembering that praise and worship is a very powerful spiritual tool. And I'll refer you to Ephesians 6:11 as well. But I think just remembering, if you always look at the problems, you're going to take your eyes off the goal. And as Christians, where are you moving towards? And always remembering that as the goal and praising the creator of that. And hopefully that will be able to provide a bit more forward momentum and loosen some of the strongholds that we're under right now.
I forgot something that's actually very important too.
Okay.
30 seconds, but I see people in the room here from Evangelical Fellowship of Canada, from ARPA, and I know the Catholic Conference of Bishops. There are actually, among church leadership organizations, this is an issue that actually has engaged them, and they've been relatively strong on some of the central voices. I know that some of the work that we did, which was initiated by the Conference of Bishops, brought faith, the Jewish community. We had various faith leaders. There was a significant interfaith statement. So I would be remiss. I was pretty negative in my description, and I hold on to that at a grassroots level. But there actually has been some significant attempts at leadership within some of those organizations from faith communities. And I think that needs to be acknowledged as well.
One thing I was going to add as well was we've spoken to this earlier as well, as addressing the demand side as well. If people have those connections and have that modeling of what death can look like, can that have an impact? And historically, much of the healthcare institutionally in Canada came from religious persons who saw needs, who saw services that were needed in healthcare and social services and did something about it. And I think that that is ultimately another way that we can address the demand is not just the top down, although I work for a think tank, I'm always going to have some top down solutions, but also how can we within our communities provide that kind of support that within our own parish churches, within our own denominations can alleviate some of the demand for MAiD because they see a real alternative. And Ray was mentioning some of the churches have exercised some leadership. There are resources out there, but a lot of church leaders are also often overwhelmed and tasked with many things. And so if we have the capacity to take some of those resources and enact them at a local level and educate people further on palliative care and help contribute to building compassionate communities, which is an organization that exists to provide that kind of care to people, then I think there's a significant difference that we can make as well.